Good afternoon, everybody, and welcome to this month's Share and Learn webinar. And I'm delighted to see that we've got a lot of attendees. First of all, I'd like to apologise on behalf of Sarah Leach, who was going to be talking to us today about creating a PBS organisational and workforce development framework, but unfortunately Sarah's been taken ill. But we now have Tom Evans from the British Institute of Learning Disabilities, who's going to talk to us about positive behaviour support and supporting people with behaviours of concern in their communities. So that links very nicely into our first topic, which Yvonne Newbold is going to introduce, who is an ambassador from the World Health Innovation Summit for learning disabilities, autism and their families, and she also has lived experience in the subject. So we'll have some time at the end of each presentation for 1 or 2 questions. If you could put your questions into the chat box, or if you'd like to actually personally ask your question if you raise your hand. As we will probably be tight for time, any questions that we're not able to answer on the webinar, we will provide a document that's sent out with the recording and the slides that answers all your questions. So now I'd like to hand over to Yvonne Newbold, who's going to talk about violence or behaviour that challenges in children with learning disabilities and autism, and how you can help to make a difference. Thank you, Yvonne.
Thank you. First of all, thank you so much for joining us today. As you know, I'm going to be talking about VCB, which is something I've done a lot of work on recently, and I'm delighted to know that you're interested in finding out more too, because the more of us that know about it, the better, and I'd love your help with it as well. We haven't got a lot of time to do much more than give it a sort of brief overview today, so basically let me get started. Now, VCB stands for Violent and Challenging Behaviour, and it's a term used to describe this sort of behaviour in children and adults who have a neurodevelopmental disorder, such as an intellectual disability or autism or ADHD. Often the violence only happens at home, and often, but not always, the mother's targeted most. I seem to be having a problem with my slides. Oh, here we are. Oh, no. Hold on a moment, bear with me. All right, here we are. That's the first slide, right. So now, although it may look the same from the outside as other forms of child-to-parent violence, the underlying factors which cause it, as well as the strategies and solutions needed to manage it, are very different indeed. VCB usually happens when a child is overwhelmed by anxiety and is highly distressed. And although to observers it may look like rage or anger, it's much more complex than that, and it's beyond the child's conscious control, so that when the violence is actually happening, it is not something that the child is choosing to do, it's not a deliberate act. Instead, it's happening because that child at that moment has completely lost control. Now, when a child has a condition like autism or ADHD or an intellectual impairment, there are lots of things that can trigger anxiety in them, much more so than in a neurotypical peer group. Things that can affect them are things like sensory processing issues, dealing with change, coping with transitions, interrupted routines and communication difficulties. Some children also mask symptoms all day long in school, so they present like a quiet, well-behaved, compliant child, and then they explode with all those bottled-up feelings as soon as they come home. When anxieties overwhelm our children, the world around them can become very confusing, and they begin to feel threatened and extremely frightened. And as this distress escalates, their autonomic nervous system can trigger the fight or flight mechanism. And once this happens, their violence is not a deliberate act to hurt a member of their family. It's more like that they feel that they have to fight for their very survival. In the moment of VCB, they are simply terrified, and their violence is an instinctive protective mechanism. They're not being naughty or disobedient or delinquent or unruly. They're in emotional meltdown and extremely distressed. But sadly, that's not what it looks like to people around them often. But once the fight or the flight mechanism has kicked in, that part of the brain that they might otherwise use for rational thinking, reasoning and judgment has also shut down. So it's very hard to reach them because they simply won't be able to process much of what's being said to them. I wish I'd known all of this when Toby, my own son, first hit me 15 years ago. Toby has profound intellectual disabilities, complex needs, and he was born so medically fragile that he wasn't expected to survive. So much so that he and I spent nearly all of his first 6 years in hospital wards and intensive care units all over London, while he hovered in that dark place between life and death, and I watched on helplessly as a resident parent. During those precious times when he was well enough to be at home, life was dominated by his round-the-clock care, and he also had this extra special talent of stopping breathing whenever he wanted, I think just to keep me on my toes. But slowly over the years he became stronger, and it was a wonderful day when he absolutely amazed everyone by mastering the art of walking when he was 10. However, communication has always been a struggle for Toby. He's now 23 and he's still non-verbal. The thing about Toby is that everybody warms to him. Despite his enormous difficulties, he has a huge personality, a slapstick sense of humour. He blows the most flamboyant kisses in the world, and he just wants to find fun in everything. And it suddenly felt like we were about to be able to put all those years of extreme ill health behind us and start living an easier life when one day everything changed. Toby hit me across the face. Shock, bewilderment, confusion, hurt. There isn't a single word to describe what it felt like. I had not seen this coming and I didn't know what to do. And within days, being hit across the face was happening at least a dozen times a day. And he was soon kicking, pulling hair, throwing things at me, picking things up to use to hit me. It was becoming relentless. Then he progressed to smashing up the house and breaking things. Now, in between times, he was his gorgeous, normal, cuddly, adorable self. But in a nanosecond, it could switch and I was being attacked again. And so were his brother and sister. Trying to keep everybody safe became my number one priority, and it was almost impossible to avoid injuries on an almost daily basis. As he got taller and stronger, he learned how to knock me over and how to kick me down the stairs. This went on for years. We couldn't go out. The other children couldn't have friends over. Life lost its joy, and we developed a siege mentality, always on tenterhooks, as to where the next episode would start. As you can imagine, we have a large multidisciplinary team supporting Toby, and I begged for help from each one of them, but the help never came. Instead, they were incredulous, disbelieving, questioning me about what I must have done to upset him first, and my parenting skills were suddenly under intense scrutiny. I was being blamed and judged, and my abilities as a mother were being undermined. It became clear that they didn't really have much knowledge of or experience of this sort of thing. And in fact, to them, I think they thought it was all a bit most peculiar. But the finger of blame was definitely being pointed at me. And also because Toby was just such an adorable cutie to everybody else, well, of course, it had to be my fault. I asked more times than I can remember whether this violence might just be part of his overall condition, and I was told categorically no. We got help in the end, but it took 7 years of begging. He was 17 before he was referred to a behavioural specialist, and of course a few months later he had to move across to adult services, so the help that we'd waited so long for was withdrawn on his 18th birthday. However, during those few months I'd learned an awful lot about the strategies that were being used with him, and we continued working with Toby, and I'm delighted to say that now he is in a completely different place emotionally, and his VCB is almost a thing of the past. Something else happened around the time of Toby's 18th birthday. I was diagnosed with bilateral breast cancer, and I had to have intensive treatment for nearly a year in an attempt to save my life. Unfortunately, the cancer treatment didn't work as well as we'd wanted it to, and a year later I was told that it had spread to my bones, that it was stage 4, and that I was unlikely to survive more than a couple more years at best. In that moment, I knew exactly what my bucket list was going to be. I knew what I wanted to spend whatever time I had left doing. I wanted to dedicate it to making the lives of the next generation of children like Toby and families like ours much better. And that's what I've been doing ever since. First of all, I wrote a book called The Special Parents Handbook, which passed on everything I'd learnt about special needs parenting in the hope that it might just make things easier for other parents. The book became an Amazon #1 bestseller, to my complete surprise, and then amazingly invitations to speak at conferences started to come in, and all sorts of other doors opened. And I'm now really blessed to be involved in lots of amazing projects. And I run training courses and workshops for parents and professional staff too. And even the cancer seems to be behaving itself. I'm on long-term treatment, but it's now 4 years since I was told I only had 2 years left. So I'm going very well indeed. Now, as you can imagine, the work I've been doing since the cancer diagnosis, I talk about Toby all the time. I'd never actually talked about his VCB publicly. I didn't want to risk the shame, the judgement and the blame, but most importantly, I didn't want to say anything about Toby that might make people think badly of him. Now, that's when I was asked to take part in the BBC Radio 4 Woman's Hour programme. It was about challenging behaviour in children with disabilities. They invited me onto the show as a commentator, not as a mother, and I had absolutely no intention of discussing our own personal experience of VCB. However, something was said, and in the charged atmosphere of live radio with 4 million people hanging on to my every word, I knew that I wouldn't be authentic unless I did share our own story. It must have made for compelling radio because Jane Garvey's team made a short podcast of just my little bit about Toby. After we said our goodbyes and I was heading back for the broadcasting house lift, I turned my phone back on and it started pinging like crazy. People were sending me messages on social media thanking me for talking about this. Parents who were dealing with their child hitting them too. A dozen messages had come through before I'd even walked outside the building, and they continued all day long. The next day, more and more just kept on coming. Emails started arriving too, and every single thing I read was yet another real-life story of sadness, terror and misery. Hundreds of them. Families living with relentless injuries, breakages and heartache. Stories of families being blamed and of desperately trying to get the help that just doesn't seem to exist. Instead, they were being forced to attend parenting classes, or they were told that their children had attachment disorders and they were blamed because they hadn't bonded with them as newborns. Some were particularly harrowing accounts of how children had been forcibly taken away from their families because VCB had been mistaken for a child protection issue. I replied to as many as I could, but in the end there were just too many of them. Reading one after another, dozens at a time, had an enormous impact on me. I was staggered at the scale of this, of how many families were just trying to survive from 1 hour to the next. I lost count of how many people contacted me in those few weeks, but it was at least several hundred. They were writing to me because they'd tried everything else and they got nowhere, but there wasn't much I could do either. I work alone as a writer from my dining room table at home, and I'm just not resourced well enough to do anything other than offer some kind words and maybe a little bit of hope by sharing Toby's fabulous progress. But in the end, I had to do something because you just can't abandon families in crisis. So I organised a conference. Tickets sold out in days, and we had a waiting list that we could have filled the room all over again. We had some amazing speakers, and it was just a fabulous day. We called it Breaking the Silence on VCB because that's what we have to do, and that's where I need your help to talk about it. We have to accept that this is happening because it is, and we have to make it okay to talk about it openly without any stigma or fear of being judged and blamed. The best part of the conference day for me was watching the relief in parents' faces when they were actually able to see and take on board for the first time that this wasn't just something that affected only their family. We created an emotionally safe, supportive and accepting space where families could share their difficulties without shame and knowing that they'd be listened to, understood and believed. And as human beings, that's all any of us really need, somebody to validate us and to try to understand. There were parents of girls and boys, of academically able children and parents of children who had severe intellectual disabilities. Children who are very fluent in talking and chatty, and others who are non-verbal. Some of the children were too little to have even started school yet. Others were now too old for school. Every child represented in that room was an individual, a potential shining star whose life is being blighted by the extreme anxiety which causes VCB. Now, these are the children who will become teenagers and then adults. These children are the prison population of tomorrow unless something is done to help their distress in plenty of time. Those who don't end up in prison may one day be admitted to an ATU facing years of medication and restraint because nothing is being done to help them now. This is a lost generation of children, and we need to find them and help them develop different ways of coping with life before it's too late. Some studies show that around 30% of people in prison have a learning disability, autism or ADHD. I wonder how many of them were once small children with VCB. And preparing for the conference, I stumbled across this research, which shocked me to the core. Studies have shown that up to 56% of all children with an ASD diagnosis will go on to develop some form of VCB, and up to 25% of children will do the same with a learning disability. Now, that means that there are likely to be tens of thousands of families in VCB crisis in this country today. And yet, just like I was 15 years ago, parents are still being blamed. We have to do better than this. I know that funding and training for PBS support workers for each of these children can't magically be sorted out by tomorrow afternoon. But I've identified 5 things that we can all do almost immediately, and you can help too. Firstly, we urgently need to change practice so that when a parent asks for help, they're listened to and believed and then treated with compassion. We need to let them know that it's okay, that this is common, and that it's very unlikely to be their fault in any way. Kindness doesn't cost anything, but it makes a huge difference to the resilience of a parent who's already nearly broken. Secondly, we can give parents information, and we can give it to them before VCB even starts. I'd like parents to be told that this is a possible symptom of their condition the moment their child's diagnosed, rather than waiting until it develops and then being shocked. Thirdly, please stop recommending parenting courses on basic parenting strategies to VCB parents who are already on a steep learning curve to master the most advanced parenting skills of anyone. I know of several parents who've been forced to complete a 6-week parenting course before their child is even allowed to be referred to the several months-long CAMS waiting list. 6 long weeks wasted while behaviour is deteriorating and the child left in emotional turmoil while their anxiety levels escalate. If you do feel that a parenting course is worthwhile, I've actually developed specialist VCB workshops which focus on the underlying causes and on building resilience in families. Something like that might be more appropriate. Number 4, please stop and think long and hard before automatically suspecting that this must be either child protection or attachment. If it's truly VCB, then it's almost certainly not caused by either of them. And lastly, please give people hope and tell them things can get better because they can. If only I'd known 15 years ago what I've since learned about why behaviour happens and how all behaviour is a form of communication. All the information I had to painstakingly research, hunt down and read up on was already known way back then, but nobody told me or signposted me to where I could find out. Parents still aren't given the information on this whatsoever, but we can change that. I'm building up resources on my website about it too, and I'd be very happy to write a leaflet for you to hand out if that helped. As well as parent workshops, I've also developed VCB training courses and workshops for frontline professionals just to help them develop the basic knowledge, skills and understanding to enable them to be able to offer a first port of call, support and practical advice to parents in VCB crisis. The training is equally suitable for healthcare professionals, education, social care staff, as well as those in the third sector. If you're interested, please email me on Yvonne@YvonneNewbold.com. I'm also in the middle of writing a book so that all this information that parents and professionals need about VCB will be easily accessible and in the same place. And I'm also working on a very accessible online video training course which will cover the same issues. I've now got a closed Facebook page for VCB parents, and it's somewhere they can share ideas and strategies and pool their knowledge. The best part of it is that they've now got somewhere to go where people will understand and offer compassionate acceptance. It's empowering and it helps to build resilience. If you're listening today because you're a parent of a child with VCB, please email me for the link to join. All along I've been asking for your help, and in a nutshell, if you're a healthcare professional, this is what I'm asking. If you're ever that person who a parent is asking for help, you've got a choice. You can choose to make them feel better or to make them feel worse. Please choose wisely. Just before I finish, I'd love to let you know that the parents on the VCB Face group have been incredibly supportive to me in helping me put this webinar presentation together. And they'd like you to see what VCB actually looks like, so they've sent me nearly 100 photos. This is only a small selection, all taken in the last week or so, and all from different homes, showing what it's like in families like ours. VCB affects families right across the social spectrum. The parents I've met are educated, informed, intelligent people. Some of them are healthcare professionals as well. This isn't something that only affects disordered, dysfunctional families. It can happen in any home, anywhere. And while you're looking at these photos, I'd like to read a poem to finish that's been written by Penny Thatcher, who's also one of the amazing mothers in this group, who copes with VCB every single day. When you've lost the will to carry on, yet feel too numb to cry, but above you is the sunshine and clouds scudding across the sky. When everything you have given just doesn't seem enough, and people keep on blaming you and everything seems tough, I try to take a second and go outside and breathe, to notice all the tiny things, the birds, the grass, the bees. At times like these, what do we need when it all just gets too much? Some praise or affirmation, or a great big hugging touch. Tomorrow is another day. I'll rise back up to fight, because in my heart is love, and I know that I am right. Thank you.
Wow. Thank you, Yvonne, for that absolutely inspirational and exceptional presentation, and for sharing your own story, your experiences with Toby, and what you're doing for parents out there is amazing. So thank you very much. We've got time for a couple of questions. First one I want to pick out is somebody, Martina Kate, who says she has to leave early, and she has got a particular question around interested whether challenging behaviour is a formal diagnosis or if it is a side effect, in brackets for lack of a better expression, to another diagnosis like ADHD or ASD, etc.
Well, as you know, I'm not a clinician, so I can't really, I'm not qualified to talk, so all I can do is explain what my understanding of it is. I would think that it's more a symptom. I don't think it's a standalone separate diagnosis. And it normally happens when the child just gets so overwhelmed with anxiety that they just reach explosion boiling point and just can't do any more. So I don't know, I'm not qualified to answer that question, I'm sorry.
Okay, thank you. We've also had some comments and questions from Julia Stackhouse, who's talking about when it actually happens the other way around, when the explosions and the behaviour happens in school rather than at home. And I don't know if you've had any experience of that with other parents and what's been able to be done to help that.
Right, it's very, very difficult, and it also is down, from what I've understood from talking to literally hundreds of parents, it is down to the sensitivity of the actual staff and the working culture in the school. Some schools are excellent and they understand that about things like sensory issues or how hard it is for children to cope with transitions. When I say transitions, that is like stopping doing one thing and then moving on to another. So, you know, basically in the school situation, it might be, right, okay, we're not going to paint anymore, we're all going to sit on the carpet and have a story. Children with the neurological conditions that we're talking about often need time to process, and not everybody understands that. It is an enormous problem that children like this are not getting the support or the understanding that they need. And it is very, very hard because, I mean, you know, look at it from the teacher's point of view as well. If they've got 30 children and one of them is running about and being really, really difficult, it's very easy for them to just treat it as a discipline problem, but it isn't. It is so different. And in fact, if you discipline a child, it will make it worse. So all I can suggest is try and give the school as much information, try and stay on side with them, talk to them. There are some children who are being supported excellently, and I know of some children who have been really, really violent in school, and they've managed to turn it around with the right intervention. And as well, I go into schools and talk to staff about these issues. So if you wanted to, you know, pass on my details, I'd be very happy to help.
Okay, thank you, Yvonne. I've got a question from Katriona Ray. What is the best way to go about talking to professionals involved with your child about VCB when you don't yet have a formal diagnosis of ASD?
Right, now that's a difficult one because obviously every family situation and every child is different and your relationships with the professionals are different, and it's, you know, I think you just have to be very honest. And I think you have to say, I do not think my child is being naughty. I think my child is anxious. The thing is, this behaviour is caused by anxiety. Now, anybody can get anxiety. You don't need an autism or an ADHD diagnosis to be recognised as having anxiety. So I would probably go down the, I'm very worried my child is anxious and this seems to be happening when they're anxious, because you don't actually need a diagnosis to talk in those terms. I don't know if that helps.
Yes, thank you. We've got a comment from Emma Richardson. My son isn't living with us now. I think early intervention and the right school setting is so important. Again, EHCPs aren't being done properly. Needs aren't being assessed properly because of money. I don't know if you've got anything you want to comment on.
I'm with Emma all the way. Yeah, the thing is, I mean, I think this is the whole subject for a whole other webinar talk, but children are being let down by schools, partly because of funding, partly because of lack of understanding. And the thing is, if we could change the culture in a school, the thing is, I don't believe there are many children who are actually born who want to be naughty. Behaviour is communication, and children don't have sophisticated communication methods. Sometimes the only way they can tell us something, particularly when they're really anxious and the words won't come out anyway, is to lash out. I would like to see a big campaign to change hearts and minds, because you don't have to actually understand very much about autism to be able to think, well, where's this child coming from? How can I help? How can I be sympathetic? How can we look at this from the child's point of view? And a lot of the reasonable adjustments that need to be made, not just in schools, and I'm not, you know, there are some fabulous schools, absolutely wonderful, dedicated teachers out there, but some children are not in environments like that. And a different mindset, a different approach doesn't actually cost anything at all, but it can make an enormous difference. Don't know if that helps.
Okay, thank you very much, Yvonne. We've now run out of time.
Okay.
On this issue. So, thank you for everybody for your comments. We will extract them and ensure that everyone sees them all. What you've
Lovely, thank you.
Positive comments that have been written in the chat box.
Thank you. I haven't had a chance to look up yet, but I will. Thank you.
Okay. Thank you, Yvonne.
Thank you.
So I'd now like to hand over to Tom Evans, who is Positive Behaviour Support Development Lead for the Institute of Learning Disabilities, who's going to talk to us about positive behaviour support and supporting people with behaviours of concern in their communities. So thank you, Tom.
Okay, I'd just like to thank Yvonne for that great talk. I'm going to echo some of the points that she's made. Yvonne started off by saying that there was always a reason for the behaviour she was describing, that it wasn't in the child's control, it wasn't that the child was being naughty. Some of the reasons may well be something internally driven, related to autism, related to anxiety, but there is always a reason for behaviour. And I guess with PBS, where we start is trying to work out what the reason for that behaviour is. Something else Yvonne said, that the children, no matter what behaviour they might be displaying, she described them as being potential shining stars, and I think that's something we'd really echo as well. We need to work out why this behaviour is happening, why the child needs to behave in these ways. Okay, I guess just to before I start the presentation, it's just worth saying, so if we can work out the reason why the behaviour is happening, then it isn't inevitable that behaviour necessarily needs to happen. And I think if families, if carers, if parents get the right support, the right professional support from people who know what they're talking about, who understand PBS, then it isn't inevitable that the situations that Yvonne was describing necessarily need to happen. So what we're all about is trying to provide that support for parents, for carers, so that the children, no matter what their behaviours, can stay in their communities, can stay with their families, working out why they're behaving the way they are. Okay, if I say a little bit about what we do at the Centre for the Advancement of PBS. Build established the centre. So we're part of Build. We were established a few years ago, and we were set up to support initially organisational workforce development of PBS in the UK, but increasingly working with anybody who's spending time with somebody with behaviours of concern. So that might be a child at school, that might be a child at home. We've worked with a number of parents over the years, and we've recently started to work with the Challenging Behaviour Foundation, who specifically set up to support families of children with more extreme behaviours of concern. So in the future, we're going to be increasingly working with them to provide support for families. In terms of the organisations we're working with currently, 100 organisations across all sorts of settings, supporting children, young people, adults. And we're also beginning to support international PBS workforce development, so working with partners in Europe, in Australia, New Zealand, around establishing PBS internationally as well. So, what I've been asked to talk about today, really briefly, is to give you an overview of what positive behaviour support is and how we can use positive behaviour support as a framework to support families, schools, services, supporting children and adults with behaviours of concern, to help them to stay in the community, near their family, near their friends, near their other support networks. I want to cover what PBS actually is. There's a lot of talk about positive behaviour support, particularly since recent scandals. And one of the reasons that I want to talk about that today is to explain what it's actually about. The point is PBS is relevant for anybody, but particularly people whose behaviour means they're at risk of being excluded, whether that's from schools or from home, or to experiencing restrictive practices, restrictive interventions and punishment as related to their behaviour. And I've put my email address there. If you want to chat about anything I talk about today, then that's my email address, and I'm really happy to talk to you about anything at all, really. So my job is very much about helping organisations, families, schools, whatever, to develop good PBS, and the reason for that is to improve the quality of life of the child, of the adult involved. But it's more than that. Positive behaviour support is about improving the quality of life of the people around the child or adult with behaviours of concern. So we're very much focused on the experience of families, of teachers, of staff members who experience the sort of behaviour that Yvonne's described. So PBS is about not just, of course, it's about improving the quality of life of the child, of the person, but it's also about the quality of life of the people around that child. We've worked recently with a number of organisations to try to firmly describe what proper positive behaviour support is. This is a document that we've produced in association with Health Education England, with Skills for Care, with the Challenging Behaviour Foundation and with the PBS Academy. So a lot of organisations, us all coming together to firmly describe what positive behaviour support is. And I'm going to take you through some of that now. This document's available on the BUILD website or on the website of any of those organisations. So the overall aim, as I've said, of positive behaviour support is to improve quality of life of the child, of the adult with behaviours of concern, but also the quality of life of those around that person. That's extremely important. If we're spending our time with somebody who at times becomes aggressive or at times damages property, either aggressive towards themselves or towards other people, that can be deeply distressing for the people around that person, as well as obviously distressing for the person themselves, but it can be deeply distressing for the people around that person. So it's incredibly important that those people are given support, good quality support, techniques to keep themselves safe, to keep the person safe, and to give that person a good quality of life, even when they're behaving at their most extreme. So what is positive behaviour support? Well, it's person-centred framework. It's person-centred, obviously. It's around the individual, so a PBS approach is always individualised. That kind of goes without saying. It's long-term. It's about recognising what this person needs across their life to get a good quality of life, so right from the child right through to older age. It applies to everybody, and recent government policy is very clear that PBS is applicable in all social care and health settings, including schools. But it's particularly relevant for people who have or may be at risk of developing behaviours that challenge us, behaviours of concern. If you were to just describe it in one sentence, I guess, it might be the next one. So it's a blend of values, person-centred values, with behavioural science. A really key aspect of PBS is that we use scientific methods to work out why the behaviour is happening. We don't guess, we don't suppose, we work out why the behaviour is happening, what's causing it to happen. Sometimes that's easy, sometimes that's not easy, and that takes a very long time. Sometimes we need professional help to work out why the behaviour is happening. As Yvonne said, that might be internally driven, it might be due to anxiety. The anxiety might be caused by factors in the environment. The person might be in pain, the person might be scared. There could be all sorts of reasons. The person might need attention, the person might need to stop doing something that they're being asked to do. But there is always a reason for the behaviour, and we need to work out what that reason is before we can plan what we need to do next. So when we're planning what to do, we use evidence, we don't use guesswork, and we make decisions around how to set up support for that person, how to arrange their house, their home, their classroom, how to talk to them, how to interact with them, what activities to do with them. All of those decisions are based on a good understanding of why the person is doing what they're doing. The values that PBS are based on are basic human rights in terms of being included in your society, in your family, within relationships that mean something to you. It's about the fact that we all need to have choice and make decisions around how we spend our lives. And a big reason for behaviour of concern is often when choice is denied to people, when people are made to do things they don't want to do or stopped from doing things that they do want to do. PBS is very much about ensuring participation and about equality of opportunity, so basic human rights, but these values alongside behavioural science are at the core of what PBS actually is. The aims of PBS, as I've said, the overall aim is to improve quality of life, and that's people around them, whoever that person might be. And it's about providing the right support for the person, but also for their family, for their friends, or for staff, paid carers if they have them. Overall, the aim is to help people live a meaningful life, but that means a meaningful life for them as an individual. Quality of life is subjective. What's a good quality of life for me and what's a good quality of life for somebody else might look quite different. There'll be some things that are the same for both of us, but there might be subtleties, and often important subtleties, that will make a good quality life for me that you might not think about. So we need to work out what makes a good quality of life for that individual. Good quality of life involves doing things you want to do, and it also means removing things from your life that things that you find difficult, make you anxious, make you scared, make you stressed. If you can't avoid those things, it's about teaching people ways of coping with or tolerating those things that we can't avoid in life. And PBS addresses all of those factors. PBS is a multi-elemental approach, so we look at the physical environment, we look at how people are talking to the person, we look at what activities they're doing, we look at their physical health, we look at their emotional health, we look at their mental health. We look at everything that's going on around the person and potentially inside the person to try to work out why, at this moment in time, this person is behaving this way. Another important aim of PBS is to avoid unnecessary restrictions. One way of dealing with people who behave in aggressive ways, typically, historically, and currently actually, is to impose restrictions. So whether they be physical restrictions, so physical interventions, restraints, whether they be chemical restraints, by that I mean giving PRN medication to sedate somebody, to tranquilise somebody effectively, or by mechanical or environmental restraints, so objects or devices that restrict somebody's movement, that stops somebody going from somewhere, stops their movement, or just restricting what they do, deciding this person can't do this activity, this person shouldn't meet this person. Very often behaviour of concern is triggered by that sort of excessive control. At times, of course, restrictions are necessary. There's always a place for restrictions to keep people safe, but they need to be appropriate and they need to be necessary. Overall, PBS is it's not just about getting rid of the behaviour of concern. It's about structuring what goes on around the person so that behaviour doesn't happen in the future, or the likelihood is reduced. It happens less, or when it does happen, it's less extreme. It doesn't happen overnight. It takes time. It's not a quick fix. But PBS is a framework for giving that person the quality of life across their lifespan. Key principles, just to echo some of Yvonne's point, behaviour always happens for a reason. There's always a reason for behaviour. Might be person's only way of communicating an unmet need. Any one of us, the more aroused we get, the less able we are to use subtle verbal communication, and the more any one of us relies on more extreme behaviour to try to get our needs met. And that's anybody, regardless of whether or not the person has an intellectual disability, autism or not. So PBS is about helping us understand why the behaviour happens, and if we can do that, then we reduce the likelihood of it happening in the future. So again, coming back to this, the key principle, we need to work out why it's happening in the first place. Okay. PBS framework, as I've mentioned, is it's about considering everything that goes on around the person, their circumstances as a whole. I've talked about physical needs, I've talked about emotional needs. Emotional needs are incredibly important, so feeling valued, feeling that people around you trust you, that they like you, even when you're having a bad day. But it also considers factors such as the impact of trauma. Many of the people we work with, children or adults, have experienced trauma, often as a result of their behaviour. They behave in a certain way and then they experience restrictions, or other responses that can actually have a profound effect long term. We need to be aware of that. PBS framework is essentially proactive. It looks to prevent things happening in the first place. So it's around trying to set up physical and social environments that meet the person's needs, that are supportive and that are capable, competent of meeting people's needs, even on a bad day. Even on a bad day. as I said before, that doesn't happen overnight. That takes time, and it often takes the objective eyes of somebody outside the setting to be able to observe what's going on in a physical and social environment, to establish that maybe it's the tone of voice that's being used, maybe it's the layout of a room, maybe it's the way the light comes through the window, particularly people on the autism spectrum with the sort of sensory differences that Yvonne alluded to. So there's a place for a period of assessment, of objective observation, to try to work out what's going on, to try to work out why the behaviour might be happening. What else? So, other key aspects of PBS framework. I've mentioned before it's about teaching people different ways of behaving. So rather than just thinking, I wish he wouldn't do that, I wish he wouldn't hit me, it's about saying, okay, when you get really cross, try to do this instead. So we try to teach functionally equivalent behaviours. We also try to look at what's making the person cross in the first place, obviously, but a key part of PBS is to try to teach people ways of behaving differently, or ways of coping or tolerating things that they find difficult. It's about trying to increase people's quality of life in all these aspects, whether it be more independent, more interesting, more meaningful. We would definitely want to involve professional input from different professionals, whether that be speech and language therapists, occupational therapists, psychologists, psychiatry, medical professionals. We certainly, PBS absolutely takes the skills from all of those professions and uses those to help understand the individual. And all this needs to be done in a planned way, in a coordinated way. It's a real challenge when you're in the middle of a situation working with somebody who is presenting you with challenges to think logically and calmly. And there's a real, so sometimes it can be really difficult to think about what needs to be done in a coordinated and planned way. So often the support that's needed from somebody outside the setting is to help them work out what to do in different situations. And again, it's those external eyes providing that support for the people who are there day to day. Okay. There's 4 factors that are critical to PBS being successful in any setting, really. Skilled and empathic staff or carers. Family members are often empathic and often do a lot to increase their skills, but I'm not sure how much support is provided to family carers or to staff. One of the things we often hear is, I wish I'd known that earlier. Where do I go to get help? And one of the things we want to do is to help family carers, staff members become skilled as well as empathic. So to have the understanding of the functions of behaviour, to have an understanding of escalation cycles, have an understanding of how to improve somebody's emotional well-being when they're calm, and how to work in a proactive manner. The other thing, the next aspect critical to the success of PBS is there needs to be people around who support those people. So we call them practice leaders. So people who have a higher level of understanding, who can provide emotional support for frontline staff, for family carers, who can complete functional assessments, who can complete environmental audits. Appropriate levels of behavioural expertise are important to try to understand why the behaviour is happening. Where this behaviour expertise comes from varies in different settings, but you need to be having an appropriate level of understanding of behaviour and behaviour analysis to work out why the behaviour is happening. And there needs to be resources and systems to support, whether that be in a service or to family. In terms of delivering PBS, I've talked about understanding why the behaviour happens. We call this functional assessment. Once we've worked out why the behaviour is happening, we produce a PBS plan, and we do that in collaboration, always in partnership with family, with schools, with the service. People need to collaborate. They need to come together with an agreed way of working. If that doesn't happen, and if conflict occurs with blame being passed between different parts of the person's life, whether that be school, service, family, that's never helpful. That never leads anywhere well. We need to be working together. We need to be sharing our ideas and our insights, wherever they come from, to develop a plan that works in the person's best interest, but also takes account of the needs of the family and staff. Once the plan's been produced, people need to be trained in it, whether that be family carers or staff. And then people need ongoing support for family carers or for staff. And one of the key parts of our job here at the Centre for the Advancement of PBS is to provide that ongoing support. Yes, we can work out why behaviour happens, we can produce plans and we can train staff, but it's that providing a provision of ongoing support that is so crucial. As I said earlier, if we are working with or caring for somebody whose behaviour is challenging, we need lots of support to do that. And one of the things we do at Build is provide that support for people. Final point here, we know that PBS is most effective when people are being supported by others, by staff, by family carers who like the person and who are in a good place with them and have rapport with the person. PBS plans, as I've said, always should be produced in partnership, ideally with the person, certainly with their family and other stakeholders. They should be produced so that everybody can follow them, so they have to be doable. They're based on being proactive, they're based on skills teaching, but they're also strategies, reactive strategies that we need to use when a crisis does happen in order to keep people safe. And if that involves restrictive interventions, of course, these must be the least restrictive. That's what the law says, that's what the government policy says. But there should also be a plan of how to reduce reliance on restriction over time. So we focus back always to improving quality of life, teaching new skills, improving emotional well-being, and working in a proactive way. So we may still need to use restrictive interventions occasionally, but the frequency of that reduces over time. Some of the things we do at the Centre for the Advancement of PBS here, so we work with a whole range of services. We assess what that might be, whether that's a family setting, whether that's a small service, whether that's a school, or whether that's a large organisation covering the whole country. We'll often review their policies and systems. We'll help them take an organisational approach, and we also facilitate communities of practice where people get support from peer basis. Some of the outcomes of PBS that we've experienced, definitely reduction of restrictive interventions, reduction in staff injury, change in staff attitude, increase in collaborative working between family, school, service, increased in consistent support, having a plan to follow, and beginning to measure improving quality of life, not only for the people being supported, but also for the staff around them. There's some resources here for you, and when you get these slides, you'll be able to get them straight away. The first one's an animation on the Build website, which explains in 10 minutes what PBS is in a very, very accessible manner. There's also a workforce development framework and some other documents here. I won't go through all of them. So these are useful documents, useful resources. There's a Yammer group there as well. So please have a look at those. Get in touch with me with anything you want to. A couple of upcoming events that might be useful. Stopping the over-medication of people with autism and learning disabilities. We're running a series of events, free events, for anybody, for family, for staff, for anybody interested. Details of them there. That's in collaboration with Health Education England. And I think that's all I have time to say. So thank you for listening, and do get in touch with me about anything I've said today.
Okay, thank you, Tom, for that very informative presentation around the framework for providing long-term support for people that, you know, maybe or have a risk of developing behaviours that challenge. We've got quite a few questions in the chat box, so we'll answer as many as we can. As I said, we will deal with those that we couldn't answer. We'll send those out separately. If I just go to the... Okay, Mary Denham asked, out of interest, is input assessment costly, and do you find schools will fund your input? I'm a professional OT, but also a parent of a 7-year-old with PDA, and she's on the verge of exclusion for aggressive behaviours associated to high levels of anxiety.
Okay, I didn't catch the first bit of the question.
Oh, sorry. Is input/assessment costly, and do you fund schools Or do you find schools will fund your input?
Okay. We're beginning to work with increasing number of special schools, increasingly being approached by schools wanting us to come in to work with them to improve PBS, and we are being welcomed into an increasing number of schools. So yes, those schools are definitely happy to commission us to come and work with them to establish PBS frameworks or to build on what they're already doing.
Okay, thanks, Tom. Catriona is asking, so is PBS really just an umbrella term, stroke framework that brings together normalisation, person-centred care, active support, functional analysis, and human rights-based care?
Certainly incorporates those things, but there is more to it than that. There's 10 key components as laid out in a paper by Gore et al., which if you go to the Build website you can look at. But it certainly includes all of those things. It also includes, definitely the principles of behaviour analysis, definitely the need for a planned approach, an understanding of functions, support plans being based on functional assessment, but also working with stakeholders with the overall aim to improve quality of life. So I wouldn't call it an umbrella term. It's about bringing together of a lot of different of those human rights-based movements that have been around for many, many years, bringing them together with an understanding of behavioural science to produce support plans for individuals, but also for the whole organisation. It's an organisational-wide approach, so it takes account of the needs of mediators, the mediators being the people who are following the support plan. So it's a framework for setting up systems rather than just a collection of approaches.
Okay, thank you. Maya Asif is asking, do you work with international schools or private schools?
All. Sorry, all. State-funded, private, and internationally as well, yeah.
And Rachel Mullen's asking any information on PBS so she can inform the school. So I think the resources at the end of your slideshow will cover that, won't they?
Yeah, definitely. I mean, first of all, give me a ring. Absolutely fine. I will talk about the work we're doing in schools. That's probably the best thing to do, actually, and we can have a proper conversation. And I can give advice around what to say to schools, the questions to ask, definitely.
Okay, thank you. So Rachel Gittins has said, what if you carry out a thorough PBS plan and present this to staff at school and respite, but they struggle to implement and be consistent with results in the family? And they refuse to continue the work in the family in crisis, and they refuse to continue the work.
The plan has to work for everybody involved. People won't follow a plan if it doesn't take account of their needs. Anybody can write a good plan, but if it hasn't taken account of the needs of the people who are having to implement it, it won't work and people won't follow it. So that's a central part of PBS. It's not just about understanding the person's behaviour, it's about understanding the people around the person's behaviour. So why won't somebody follow up a support plan? We need to work that out. Why is there resistance, reluctance, mistrust? There's reasons for everyone's behaviour. That includes teachers' behaviour, staff behaviour, family members' behaviour. So we need to take account of all of that and produce a plan for all of those people so that all of those people can follow it. If the plan's not being followed, the plan needs rewriting.
Okay, thank you. So we've got time for one last question from Rachel. Are you able to direct me to an evidence base for using PBS with children and young people with ASD, stroke learning disabilities and behaviours that challenge, please? Locally, we're considering training our CAMS workforce up in PBS.
Yeah.
Oh, I've just lost it.
Yeah, definitely. I mean, again, get in touch with me. I don't have the reference, the research references to hand, obviously, but get in touch and I'll pass you on to the. I'll give you the references of the research that shows the evidence base. Increasing evidence base internationally and in this country and abroad.
Okay, fabulous. So we've come to the end of today's webinar now, so I'd just like to thank both Yvonne and Tom for your excellent presentations and contributions today, and also to our audience for spending the time to listen to our presentations. Next month at the webinar, we'll be focusing on a training session for TCPs on assuring transformation data systems. And then in August, we have a team that's going to be talking about the NHS England's Insight and Learning Disability Engagement team have some bite-sized guides to helping people with a learning disability to give feedback. So if you're interested in either of those webinars, then please do join us. And again, I'd just like to reiterate that Sarah will be doing her presentation in October. So thanks everybody, and we'll speak next month. Bye-bye.